welcome to our fifth webinar in our breast health series as we follow patient pathways from screening mammography to surgery. In our last episode, we talked with our physician panel about breast biopsies and the types of pathology results a patient may receive. Some of these findings mean that a patient will need surgery to remove the lesion because it's causing pain or discomfort, or it's a high-risk area, and in some cases, it's cancer. So what are the next steps? Well, it depends if the lesion is palpable or not, meaning your doctor can feel the area upon exam. If it is palpable, then your surgeon will be able to find it during your surgery the same way. But if it isn't palpable, they'll need a way to guide them to the area. That procedure is called a lesion localization. In today's episode, we're talking to our physician panel about the available localization technologies today, so we can better understand the choices patients have and what questions they can ask before their own procedure.
Hi, my name is David Weintritt. I am a breast cancer surgeon in historic Alexandria, Virginia. I have a position in the faculty of the Department of Surgery of George Washington University and a directorship of a program in the Inova Health System in Northern Virginia. And I also run a breast center and a breast cancer foundation in my practice in Alexandria.
Thanks so much for having me. My name is Ann Pellid. I'm a dual trained breast cancer and breast plastic surgeon. I practice in San Francisco and co-direct our breast program at Sutter Health, California Pacific Medical Center. I'm also a breast cancer survivor myself, so I'm always really happy to connect with patients and providers around that experience as well.
My name is Dr. Beth Dupree. I am a breast cancer surgeon and I work currently in Sedona, Arizona. I've been in practice for over 30 years where I have chosen to limit my practice to the diseases of the breast.
Hi, my name is Barry Rosen. I'm a breast cancer surgeon in practice in the northwest suburbs of Chicago. And it is a pleasure for me to participate in any program that can help educate our patient population about the latest and greatest innovations available for breast cancer screening, diagnosis, treatment, and prevention.
I'm Ranjana Chatterjee. I'm a breast surgeon in New York. I practice at a community hospital, Northern Westchester Hospital, which is a part of Northwell Health.
So a patient may have a breast biopsy and they're given their results, and whether it's something that is just atypical or high risk, or they do in fact have a breast cancer, the pathway then would mean that they were sent over to you as a breast surgeon, and one of the procedures they would have would be called a lesion localization. So can you talk to us about what is lesion localization and what is the process?
So more and more these days, we're finding cancers that are smaller and smaller, and that's fantastic. That really gives us the best chance for cure when you find a cancer before it's palpable. Well, if you can't palpate the cancer, how are you going to find that cancer in the operating room? Many times it feels like looking for a needle in a haystack. And the traditional means for cancer localization at the time of surgery is that a woman would go down to the breast center the day of surgery, and the radiologist would put a wire into the breast. And that's why we put clips in, by the way. So when a woman has a biopsy, a clip is placed. And that way, the radiologist, the day of surgery, can put a wire into the breast, and that wire will sit at that clip and come out of the skin. And that is what I like to think of as the best of 20th century technology. And yes, it allows us to localize the cancer, but it's a very imprecise method of localization because a surgeon can't feel the tip of that wire. A surgeon can't see the tip of that wire. It just gives us an approximation of where the cancer is. Well, if I have a cancer that's a size of the pea, and you think of a large-breasted woman with a pea-sized cancer and a small, thin, flexible wire sitting in their breast, how precise am I going to be removing that cancer? Not very precise. So how do I overcome that precision? By removing a large specimen. Well, the larger the specimen, the worse the cosmetic outcome. The other problem with the wire is that the less precise I am, the higher the likelihood that I am going to not perfectly remove that cancer, so that when we look at the cancer under the microscope a few days later, we're going to find that the margins are positive. And in the United States, when a woman has a lumpectomy, there's a 15 to 20% chance that they're going to need a second lumpectomy because the margin turned out to be positive. So the more precise I am with localization, the better the cosmetic outcome I'm going to have for my patients, and the lesser the risk of having to go back and reoperate. Now, let's not also lose sight of the fact that it's not fun walking around with a wire sitting out of your breast either. So wire localization is unfortunately still the norm in the United States.
Can you explain how moving to a wire-free device has benefited you as the surgeon, and also the benefits that a patient might see?
When it comes to localization of a breast mass for excision, cancer or otherwise, the benefit of using a wireless device is really begins at the beginning and then travels all the way through to the end of the surgery. So to begin with, there's this concept of decoupling radiology and surgery. Historically, when women had a target in the breast that required localization and it was done with a wire, they would have to arrive much earlier the day of surgery. And in actually not an insignificant number of institutions, even go to a different department and then travel by car or some other mode with a wire out of their breast to the surgeon and then have it removed. Using wireless systems allows placement of the chip or tag or marker days, weeks, or even months ahead of surgery. So the patient can actually show up for the day of their operation and not have to go through the additional effort of an hour or two in the radiology department. We don't have to worry that their travel by foot, wheelchair, or car from the wire placement to the operation has resulted in that wire moving or becoming dislodged, which would be a really bad event. So not only do they allow a more user-friendly, both for the patient and surgeon, placement of a localizing device, they allow for a more accurate identification of that area of concern during the surgery.
So Dr. Rosen, can you speak from the patient's experience? You know, they may have had a mother, a sister that in the past has had breast cancer surgery, and they had a wire put in the morning of surgery. What is that patient experience like that morning of versus if they sought out a facility that did wire-free localization? What is that patient experience like on the day of surgery?
A wire is a miserable experience to put a patient through. First of all, they've been fasting, and you take them to the breast center, you stand them up when they haven't had anything to eat or drink, and you start putting wires in their breast. They're anxious enough because it's their day of surgery. They're dehydrated. Well, what happens? These women sometimes get vasovagal and faint in the breast center. Much less the anxiety added to putting the wire in and then walking around for X number of hours until the operating room with a wire sticking out of their breast. It's not a good experience.
I always felt terrible telling patients that they were going to come to surgery on a day they were already anxious about breast cancer surgery or surgery in general. And then we're going to tell them they have to go get wires placed into their breast. And that just always felt awful as a surgeon telling people that. So for me, I love that idea that now it's a little procedure you're going to have in advance. And so people have a lot less anxiety about it. And then of course, ultimately for the patients, it's a better experience for them. People don't have the anxiety they used to have around wires. I'm not prescribing Valium to all my patients to get through wires, which I love. So I think really, truly, it's a win for everyone.
When I started training 30 years ago, the localization technique we used was rather barbaric in comparison to what we do now. Fast forward to a time where everyone's trying to solve the problem. How do we make this better for patients? So these localization devices are put in prior to surgery, many times weeks to months, so it makes the process better. There's nothing you can feel from the outside. And then in the operating room, the surgeons are able to use a detector of whatever variety is required to find that device and allow us to hone in right at that area and be able to remove that lesion. So it gives us a better chance to be able to get negative margins or be able to create a surgical cure at the time of the definitive surgery.
Dr. Chatterjee, how would you say that using a wire-free device has affected your surgical techniques and outcomes?
It really kind of opens up more opportunities for us for patient-directed care. Just such a game changer in that it's so streamlined, and I can feel very confident in the tissue that I'm removing and knowing exactly where I'm going. And so I just feel that when you're doing the oncoplastics, you're not having to go to the point of the wire entry and then to the lesion. You can just go directly to the lesion. So it's just sort of aiding you in having more accuracy in where exactly you're going. And so it just leads to, I think, like taking out less tissue in general. When you don't have the wire track marks some patients would get in their skin years after surgery. So you're kind of avoiding that. And just the ease of patient scheduling. And they are, oftentimes if you're doing like 4 or 5 cases in a day, women's imaging would have certain, morning slots available for the wire. And you could have a patient waiting around for like 4 to 6 hours waiting for their turn for surgery. And they've had a wire in them. And so that was one of our biggest complaints that sort of helped us kind of go towards the wireless localizations.
What would you like to tell patients about the options that they have today using a wire-free technology for their localization?
So localization technologies have changed the face of breast care. It really has become a much more patient-centric process. And so it's something that if a woman is going to undergo a surgical excision of a lesion that's already been biopsied, and if they're being told they need to put a needle in the breast and keep the needle there for several hours prior to surgery, they should vote with their feet and identify a surgeon utilizing intraoperative localization techniques that are state-of-the-art and now what I consider standard of care.
Why do you think it's important for a breast cancer patient to search out a dedicated breast surgeon? And how would you advise that they go about doing so?
I really do believe it is important for patients having surgery for breast cancer to search out as a surgeon who is dedicated to that disease. It does not have to be the only version of surgery that surgeon provides. Myself, many other surgical oncologists or surgeons who primarily focus on cancer may treat other versions as well, but it needs to be the main focus in something that they are very familiar with and at the forefront of that disease. Part of it is there are tremendous variety of options now available that surgeons who are not familiar with breast cancer may not really have the ability to offer or may not even know to offer. So it begins with making sure that, as I view it in my practice, my goal is I don't want there to be any viable option on the planet that we are not able to understand and, when appropriate, offer to our patients. And that's a big goal, but I think that means you have a team, and obviously there are many others, where they have the mindset of, this is my job, I need to master this for the benefit of our patients. And how patients find someone like that, I belong to a society, the American Society of Breast Surgeons. I think that's a very good filter. It's a group that has designated themselves as interested in mastering and forwarding and promoting the appropriate way of doing breast surgery. If patients also can talk to the surgeons and ask them what percentage of their practice is involved in breast cancer. Do they participate in research related to breast cancer? What are their outcomes? They can really, I think, achieve or try to look into the skill set and the mindset.
Thank you for watching today. We hope you found this discussion on lesion localization helpful and informative. You can view the rest of the Breast Health series by scanning the QR code or clicking the button on your screen. Don't forget to check out our downloadable resource section and the sharing option so you can send the series to a friend. In our next episode, we'll be diving into the surgical options available today. and hear about the different treatment pathways patients may take depending on their unique diagnosis. We hope to see you there.